Thanks for coming to seminar today. It's my pleasure to introduce Dr. Aparna Ramasubramanian. Dr. Ramasubramanian is an assistant professor of pediatric ophthalmology and oncology at Harry U of L. She attended medical school at the University of Kerala in India and did her ophthalmology residence at Indiana University. Her fellowship in ocular oncology was at the Wills Eye Institute, and her fellowship in pediatric ophthalmology was at the Children's Hospital in Boston. Her primary research and clinical interest is in retinoblastoma, and she's the author of the leading textbook on this topic of retinoblastoma. She's published extensively in peer-reviewed journals and is a reviewer for all leading ophthalmology journals, and she's also the program developer for the retinoblastoma campaign by the Children's Eye Foundation. So I'm happy to introduce her as my collaborator.
Thank you. Thank you, Jill. So before we start, can I just get an idea on what you guys are doing? Are you all bioengineering students? And what level of training, what level of school are you guys in?
Masters.
Masters, okay. So
Seniors.
Seniors, okay.
And juniors too.
Okay, so just like a mixed bag. Okay. So basically, I didn't want to go too technical in this lecture, but I'm basically touching on the concepts of what my specialty does. I'm predominantly going to talk about ocular oncology today. Ocular oncology is anything to do with eye cancers. It could be primary cancer in the eye or cancer elsewhere in the body that has affected the eye now. And just basically talking about how we can integrate bioengineering with my specialty. What are the things that have been developed so far which has changed things drastically for us, and where are the voids? So you guys are all fresh young minds. I'm just showing you the voids on what we need. So if an idea clicks for one of you, you want to pursue it, you'll at least have an avenue. Because the problem is, if you do research without an end at sight, I don't think it doesn't lead anywhere. Whereas if you know this is what is needed, this is what we need to do, then it kind of makes more sense. So that's the purpose of this lecture, and we can make it very interactive. So stop me at any time. We don't have to go through the whole lecture and then bring up questions, okay? Because sometimes we are so much in the medical field that some terms are just very routine for us, but it may not make sense to somebody else. So just stop me at that time if you don't understand what I'm trying to say or the terms, okay? So I do not have any financial interest in any of the material provided. So we're going to first talk about retinoblastoma. It's my central interest and my passion in life. So retinoblastoma is actually an eye cancer that occurs in children less than 5 years of age. And this is what it presents as. On the left side, you'll see that the pupil looks fine, whereas on the right side, you see a white glow in the pupil. And that is the tumor in the back of the eye. And this is how majority of the retinoblastomas are detected. So like I said, it's the most common intraocular, means inside the eye malignancy in childhood. There are 1 in 15,000 live births, that's the incidence. Approximately 300 new cases in the United States every year. So not a very common cancer, but still an important one because it's very malignant. Untreated, 100% of them die. And Louisville, fortunately, is one of the 6 centers in the country that treats retinoblastoma. It's a very specialized cancer, so there are only a few centers that treat it. The mean age of onset is around 18 months, so very teeny tiny babies, and there's no sex predilection. As you can see in this picture, dad had bilateral retinoblastoma, meaning retinoblastoma in both eyes, has had both eyes removed unfortunately, and has had radiation to both eyes. That's why you see the face structure just looks different. And it is a familial disorder, it is a genetic disorder. So the daughter has retinoblastoma also, but you can see that dad was probably treated in the 1960s, 1970s, when treatment was not as available. I mean, there's no better treatment than removing the eye. We saved the person's life, but we still have to remove the eye. Whereas daughter is probably born in the 21st century, newer treatments, gets to keep both eyes, has reasonable vision in both eyes. So as you can see, there's a drastic change in how things have been treated previously and now. And I would say even in the last 10 years, a lot has changed. And hopefully with the work that myself and Jill are doing, we'd be able to better things even more. So briefly about the genetics, it is an autosomal dominant condition. Do you guys understand autosomal dominant recessive? All that great. And there's 90% penetrance. So not everybody gets it. 10% of them have a family history of retinoblastoma. The others are mutations that are just happening sporadically. Okay? So if you look at the survival statistics, even in 1963-67, the survival was not bad because fortunately we have a localized organ like the eye, and we can just remove the eye and prevent the cancer from spreading outside. So that's why even in the 1960s, the survival was not terrible. It was 85%. But currently the survival is close to 100%. And like I said, untreated, it's 100% fatal. And why it's kind of interesting is retinoblastoma, among all cancers that inflicts humans, it has the best survival with current day treatment. So if you pick it up early, treat them appropriately, you get very good results. The current treatment, of course, there are many options for treatment, and it's all tailor-made for the patient. We see how much tumor they have, which eye, both eyes affected, one eye affected. There are a lot of parameters based on which we decide treatment, and often multiple treatments are needed for these patients. But basically, we have local treatment, we have chemotherapy, we have radiation, and of course, we sometimes have to remove the eye. Today we'll predominantly talk about chemotherapy, though later we will talk about the local therapy just a little bit. So before we talk about the research that we are doing, let me quickly talk about another new way of delivering chemotherapy which has drastically changed things. When you think of chemotherapy, you think of people getting chemo shots every month. They lose their hair, they're really sick, they get infections, they lose all their hair, and this is how traditionally chemo was done even for retinoblastoma. It was given, the whole body got the chemo, and there's toxicity everywhere. But now we have a better way. And again, this has a lot to do with how catheters are devised, how bioengineering has helped us in making things more tailor-made approach to the tumor. So now what we do is we go through the artery in the leg, we go all the way up to the carotid artery, which is the artery in the neck, we go to the artery in the eye, which is called the ophthalmic artery, ophthalmic means eye, and then we give chemo just to the eye. So none of the rest of the body doesn't get it, only the eye gets the chemo because that's where the tumor is. So makes complete sense, right? So most of you can, I think, appreciate these pictures. Maybe the ultrasound makes more sense. This is the ultrasound of the eye where the original tumor, you see how big it is? It's filling almost the entire cavity of the eye, whereas after just that localized 3 cycles of treatment, you see the tumor has really shrunk down very nicely, and this is predominantly just dead scar. So this kind of treatment works very nicely. Just another example, it's kind of harder for you guys to appreciate real photographs. I think it's easier to appreciate just the ultrasound pictures. You see much larger tumor in the beginning, it's really much smaller now. So this kind of chemo really works very well. Again, very large tumor in the beginning, just shrunk down very nicely. Now, sometimes, I don't know if you can appreciate this, but if you see, this is the tumor that has shrunk, but you see all these spots here, they are actually portions of the tumor. They are seeds of the tumor that are just floating in the eye. They're actually cancer cells. And those cancer cells that float in the cavity of the eye or the vitreous of the eye is what bothered us the most, because the vitreous has no vessels in it. So no matter where you give the chemo from, it never gets to this area, and this was the predominant reason why most of the eyes had to be removed. And we could never give an injection in the eye for a child with retinoblastoma, because as your needle comes out, the cells of the tumor come out, and they go to the rest of the body, and the child unfortunately dies. So this was what was the original thinking. We knew that we cannot inject a needle in a tumor eye, but now things have changed slightly, and this was This was a paper from Switzerland. We started a new technique of doing these injections, and that is what we do currently. This is me treating a child. Where we first do a scan, make sure there's no tumor in the front part of the eye. We take a little sample of the tumor, of the fluid of the eye, make sure there's no cancer cells in it, and then we go ahead, give the injection, and as we come out with the needle, we do a little freezing treatment right at the entrance. So if cells are trying to come out, we kill them immediately. So with this new technique, it's pretty safe to do these injections. So you see over here, there's just all these tumor cells, and after I believe this child had 7 injections, there are no cells there. These are just dead cells. So this treatment works very nicely. Another child, this is the child's only eye because the other eye ended up being removed. See, extensive cells, and just with, this kid actually got 10 injections and hardly any more tumor remnant there. And just I can show you more and more pictures, but anyway, you get the idea that we can give chemo right in the eye and it will kill the tumor cells. But it has its own complications. This child had an injection elsewhere, fortunately not by me, but then developed a very adverse reaction to the eye, kind of like an infection in the eye. And this is a pathology where you can't see any eye structures. Basically, the whole eye was what we call necrotic. There was no healthy tissue there. It was just a completely necrotic eye. So that was the complication of that patient. And whenever we do an injection, we kind of get tissue damage on the site where we have injected because we're injecting chemo. So there's always a lot of problems. So the current practice is that we do injections every 1 to 2 weeks. And they need up to 8 to 12 injections. Every time you go to take these kids under anesthesia to do it. And there's a lot of risk factors. Every time you stick a needle, there is a small chance you're bringing cancer cells out. There is a risk of infection like that child had and lost the eye. The risk of retinal detachment, retina is a tissue in the back of the eye. The risk of retinal detachment is very small but still existent. And then the damage to the normal cells. And of course, with every anesthesia, there's a risk. And you know, if you look into it, these kids probably get like 20, 30 surgeries in their whole lifetime. It's accumulative anesthesia risk. It's linked to cognitive damage later in life and all that. So if you can limit anesthesia, we want to limit it. Of course, you would choose mild cognitive damage over losing a life, but still, you know, if we can minimize all those things, we would like to minimize. And that's where myself and Jill's work comes in, where we are trying to create a nanoparticle MELPHALAN. MELPHALAN is the chemo that we currently use. We're trying to create a nanoparticle MELPHALAN for these intravitreal injections so that we won't have to do as many injections. Maybe we can get away by doing 1 or 2, and it's going to be a slow release compound that's going to release chemo over time, or maybe even more effectively, so we won't have to keep doing this. And we have a grant from Knights Templar Eye Foundation, which is a leading pediatric ophthalmology grant for the work. And let's just look into nanoparticles in retinal problems. And I think the eye is kind of an interesting organ system in that we have ability to give, be it chemo or not chemo, be it for any condition, it's a very localized structure. The tissues are right there. We have access to give whatever medication right to the end organ. Supposing you take a pill and it has to go to the liver, you still have to take the pill either by mouth or through your IV, and it has to go through multiple other tissues to get there. In the eye, we have the option of giving it right to the end organ. So that's why I think it's an interesting area for, you know, furthering development. With systemic delivery for the eye, the problem is that there is what's called as the blood-retinal barrier. There's a barrier between, there are blood cells that create barrier, and there are retinal cells that create barrier, and because of which the drug cannot reach where it needs to reach. And then there's also rapid ocular elimination. So that's why we try to create these slow release particles with nanoparticles. So that's the problem with systemic delivery. With intraocular injections like this, if you can go directly into the eye and inject, there's always this problem that you have to keep giving them repeatedly. And then with every subsequent injection, there's more adverse reaction. So, and the MELPHALAN has been tested to be the most effective treatment for retinoblastoma, but it has its own problems. Once the chemo is there, it's very effective in killing the cells, but it's a very unstable molecule. And once the pharmacy mixes the medicine, it has to go into the eye within half hour. So we actually have pharmacy mix it, and like somebody rushes it to the operating room. I'm already in the operating room for it, and then we inject. So there's a lot of logistical problems with it. And the longer it sits, the more unstable it gets because it starts creating precipitates. And it's these precipitates that create problems for us. It's these precipitates that precipitate on the tissues. When we give them through the intraarterial approach, remember we talked about giving the medicine just to the eye. Again, these precipitates precipitate in the artery, they clog up the artery. So it's a lot of problems with the MELPHALAN. And that's why we're doing this study, where what Jill is trying to do for us is to create nanoparticles using with the medication MELPHALAN, and then we'll study it in retinoblastoma cell lines, and then we'll study it in a murine model, and hopefully we'll go into clinical trials very soon. Our goal is for a couple of years. We're hoping that in a couple of years we can finish the murine model and go to our next step. Okay, and this is the work Jill has already done. We're going to start cell line studies very shortly, where these are just, so she has incorporated the MELPHALAN as a nanoparticle, but in addition to that, she's also looking into surface modifications. And if you have any more questions about this, don't ask me. I have no clue what she's doing with the surface modifications, but Jill is here, and she can tell you more about that. So these surface modifications will just help in getting to the organ tissue in a more effective way and prevent its lysis in the organ tissue. So any questions about this so far? This is kind of the work we have already done. From here on, what I'm going to talk about is some ideas that you guys can pick up and work or something like that. Any questions? Yes?
You mentioned the 30-minute shelf life. So why can't it just be mixed in the surgery room?
It needs a special chamber for mixing.
Okay.
We can't do it in open air. You need what's called as a chamber. Yeah, I would have loved to have a chamber in the operating room itself, but at least we have a pharmacy that's right next to the operating room. There are some places, the biggest center that does this in England, actually their pharmacy is across the street. And they always tell me stories about how people have to dash through the road to bring it to the operating room. At least in ours, it's just the next door. Yes.
In the beginning, you told that injecting chemo in the eye can cause cancer cells to move through the body. Could you please explain why they move through the body, those you are injecting directly in the eye?
Very good question, actually. So what happens is the tumor is actually limited by the walls of the eye initially. Only when it spreads beyond and extend does it go out. So when we are injecting a needle, what happens? Retinoblastoma cells are very adhesive cells. So supposing your needle has touched a tumor cell, that it's very adhesive. It's going to stick to my needle. It's going to come out to the white part of the eye or the conjunctiva. Now the conjunctiva has lymphatics and it has blood. So now what was walled in the eye, we brought it out. Now it's going to spread. That's the problem. There have been instances where people have accidentally done a biopsy, not knowing that it's in retinoblastoma eye, and those kids have all died. Yeah, so the problem with retinoblastoma, unlike so supposing you have a tumor, supposing I have a tumor in my arm, what can I do? I can just go and cut off the tumor. With retinoblastoma, I cannot do any open surgery. Because same problem. Every time you go in and try to do surgery, you're just seeding cells outside. That's why you've got to look at other avenues for it. Any other questions? Okay, so I'm going to talk about another thing about retinoblastoma before we say enough of retinoblastoma, though I can talk about it all day, all week, all month, is the photo screening of retinoblastoma. You remember our first picture that we saw that picture with the yellow glow? That's what picks up the tumor. The earlier you pick up, the better the life prognosis. So we have actually, so the problem with current day iPhones and all smartphone cameras is that it blocks the red reflex. We actually want to see that red reflex. When you see those when you take pictures of yourself and you see that the red reflex, you have the red blocking. We actually want to see the red because it tells us healthy retina. So we have actually now created an app for, we are currently working on iPhone for it. But we are creating this app which still incorporates the red reflex so we can look at it. So again, the same thing, smartphones have that red reflex blocking. The ancient age-old cameras used to pick up retinoblastoma way better than the newer phones. And you can guess, it's been proven what are the months of the year when retinoblastoma gets picked up the most. Around the holidays actually, because that's when maximum pictures are taken of families and kids and all that, and then things get picked up. So it's maximum around the holidays actually. So this is the app that we are currently testing. It's already, we have not released the app yet because we are testing the scientific validity for it. So far we have done 257 children that were tested with the new app. The average age was 6.5 years. This is just the breakdown. The other advantage of the app is that it detects not just retinoblastoma, but it detects a lot of other problems in the back of the eye, and it also detects if they have a significant eye problem in one eye which needs to be treated at a younger age. So that's what the word amblyopia means. So basically, so far, so this is just a normal picture using the app, and this is a picture of a retinoblastoma child with the app. And if anybody's interested, the app is on my phone. I can show you how it works. So far in that 257 children pilot study that we have done, it seems to work really well in Caucasian and Asian eyes, and Hispanic also for most part it's working, but in African American eyes with darker pigment, it doesn't seem to be working well. So we're trying to modify the app. I think we need a little brighter light in order to get a good red reflex. So we're just modifying the app, and then we're going to do a more extensive, we're planning to get at least 2,000 children in the study to test the app before we actually release it out. So fun things like that can be done for ophthalmology also. Okay. Any questions about photo screening? If anybody's interested, there's a lot to be done for photo screening, not for retinoblastoma, but just to pick up eye problems in children. It's a huge industry out there. My mentor in Boston has his own prototype. He has an engineering background, and then he went into medical school and pediatric ophthalmology. So he has a dual degree in engineering and medicine, and he created this prototype. They're called as photo screeners. If you're interested to see, you can Google it. They're called as photo screeners, and they're actually currently, if you have other family members that are taken to pediatric offices now, they do the photo screening instead of making kids read the chart, which is painful because half the time they're just goofing around, they don't want to read the chart. So they are called as the photo screeners. So it's based on the same principle, but just an app and phone model of it. Okay. Okay, let's talk about the other tumor that's most common in the eye. It's believe it or not, melanoma is the second most common site for melanoma in the body is the eye after the skin. So it's not uncommon. So it's the most common primary intraocular tumor in adults. Approximately 2,500 adults are affected every year in the United States. And this is what the tumor looks like in the back of the eye. And for you these might be just spots, but for us these spots are the most important thing, because these spots are what is called as orange pigment. And thanks to bioengineering methods, we now have what's called as an autofluorescence picture, that really brings out these spots. When you get these autofluorescence pictures and you see these spots, you know it's a melanoma and it's not just a mole in the back of the eye, because moles are very common also. And we've got to differentiate between a mole and a melanoma. So the spots are really important, and something that is of my interest, but I wish somebody would pick it up for me and work on that, is that those pictures are in adults. In children, unfortunately, we can't do those pictures. So we use what's called as a ret cam, where that's the handle of the ret cam. When the kid is under anesthesia, we hold it on the eye and take pictures of the eye. Unfortunately, ret cams don't have autofluorescence. And there's a lot of things that we can use the autofluorescence in. So I wish somebody would work on this, build an autofluorescence into this machine so that we can just use it for a lot of applications. Autofluorescence is used extensively in ophthalmology. And I would say it's probably been around for 12, 13 years now. It's really changed management of ophthalmology in a lot of different diseases. I'm not talking just oncology. So that's that. So for melanoma, what we do is we actually place a radiation device in the eye. This is a gold-plated ring. You see those lines there? They're actually iodine seeds. And we make a plug that's custom made for the patient, for the tumor. We sew it on the eye like that. It stays there for 3 to 4 days, and then we just remove it. And actually, we can use the same treatment for retinoblastoma also, because we're not entering the eye, we're just sewing it on the surface. So we can do this for retinoblastoma also, and I do it for retinoblastoma also. So this was the melanoma before, and this is up with the radiation. See, it's a very flat scar. But what do you think the problem is now? The tumor is all dead. What do you think would be the problem now?
So damage to the eyes when there's not very good vision.
Very good, damage to the eye, because this is the optic nerve. The optic nerve is probably pretty damaged. The central part of vision is pretty damaged, because there's no way for us to say, oh, radiation, you just stop at this border here. Healthy tissues are going to get affected also. And I mean, it's fine, they live, but their vision is probably severely hampered with that. The other treatment that we can do is kind of laser treatments. There are 2 kinds of lasers that are available. One is a transpupillary thermotherapy, which is kind of like a diode laser. It's an 810 nanometer wavelength. The other is what's called as photodynamic therapy, where we give a photosensitizer by the vein and then do laser. This is a little softer than that one because it's less damaging to normal tissues, but both these lasers are not as effective. The really nice thing is that you just have a headpiece with a laser in it, you just look at the tumor and you just zap the tumor. So the delivery is very easy. The delivery system is very easy, but unfortunately it doesn't work very well, very high recurrence rate. So we need better. What works for tumor is not laser, but radiation. And I know it sounds very simple to say, let's make a radiation that can be delivered through my headlight, so I can just go in and zap the tumor instead of keeping the radiation on the eye for 3-4 days. Easier said than done, because I guess you guys will understand that more than me. Because I will say, I want radiation to come off the forehead piece so I can go zap the tumor, but it's up to you guys to decide how the radiation can be fitted on that, how it has to be delivered, how there will not be scatter. So I've spoken to a few people about this, and apparently it is a difficult model, but I think that's where we need to go. And if we do that, it's not just melanoma, but every single tumor can be treated like that. Retinoblastoma can be treated like that. We don't have to do chemo anymore. It will save a lot of things. So if any of you can come up with those ideas, awesome. So again, the other thing is choroidal metastasis. It's when, you remember we talked about it can be tumor elsewhere in the body, come into the eye. That's what is metastasis. They have cancer elsewhere in the body and it just comes to the eye. So it's the most common tumor in the eye, putting everything together. The most common site is the back of the eye. 25% of them already have a history of cancer, and then 10% of them, 25% do not have history of cancer elsewhere. We are the first ones to detect it. And in 10% we can never find out where it came from. I'm actually currently treating a patient like that, but we don't know where it's coming from, and it's only 40. So it's very sad that there's cancer everywhere, but we don't know where it came from. So the most common site is breast in women and lung in men. And usually multiple treatment options are available. None of them are very effective, and unfortunately in these situations, the life prognosis is not very good. Usually around a year is the survival, because the cancer is everywhere. The last thing I'm going to talk about is what's called as graft-versus-host disease. Basically what it is for people who get bone marrow transplantation, it's the normal cells are fighting against the recipient cells. That's called as graft-versus-host disease. And it produces severe dry eye in the eye. And it just sloughs off the tissues in the front part of the eye. And why this happens is there's a tear film. You don't think so much about your tears, but the tears actually have 3 layers to it. The bottommost layer is the mucus layer, the middle layer is the aqueous layer, and the surface layer is the lipid layer. It's actually the lipid on top that's preventing the aqueous from drying out constantly. And people who have graft-versus-host disease, they have a problem in the aqueous. They hardly have any aqueous production, and on top of that, that lipid is abnormal, so it evaporates faster. They don't produce as much, and it evaporates faster also. So, and 60% of your patients who have graft-versus-host disease will have eye problems. And usually we treat it symptomatically. We just give them a lot of artificial tears. You know, it's not very effective treatment, but for most part we can control it quite well. But what is really nice now is that now we have hyaluronic acid, which is probably the biggest contribution of bioengineering to ophthalmology. We use hyaluronic acid in everything, but predominantly we use it during cataract surgery. And we cannot imagine cataract surgery without hyaluronic acid. So if I had to name one thing that bioengineering contributed to ophthalmology that made the most impact, I would say hyaluronic acid. So now we have hyaluronic acid available as eye drops, which is great because it doesn't evaporate as quickly. But from my standpoint, what we are looking at is we are checking the human sebum secretion in graft-versus-host disease patient, comparing it to normals and seeing what's wrong with the lipid that this is happening. So that we are doing with spectroscopy. So that's just briefly about graft-versus-host disease. And not just because you're bioengineering students, but whenever I get a chance, I do talk about this. This is a poster campaign that we have launched in Kentucky. Because unfortunately in Kentucky, I am detecting retinoblastoma way later than I want to. The tumors are classified as A, B, C, D, E, and I see only group E here. I want to see them at A or B level. I don't want to see them in their E. So, you know, spread the awareness on the yellow glow. If you ever see any of your friends, families, anybody's picture that has that yellow glow, tell them to seek medical care immediately. Okay? I'm happy to take questions, comments.